Hello, and welcome to Skin of Color Savvy, the art and science of treating patients of color, the official podcast of the Skin of Color Society. Produced by HCPLive and hosted by Skin of Color Society leaders, Skin of Color Savvy delves into the latest research, the clinical insights, and cultural intelligent and responsive care practices in dermatology with leading experts. I'm Dr. Amy McMichael from the Department of Dermatology at Wake Forest University School of Medicine, and it's my pleasure today to be joined by Dr. Kayla Taylor, a dermatologist in the Atrium Health System. Good morning.
Good morning. I'm
So
great and
lovely.
happy to be here.
Oh, so lovely to have you. Today, I'm going to let you give just a couple of words about you, your interests, and kind of introduce us to the topic we're going to be talking about today.
Yes, so my name is Dr. Kayla Taylor. I'm a dermatologist in Charlotte, North Carolina, with the Atrium Health System, and then I am an assistant professor of dermatology at Wake Forest School of Medicine. I got my initial interest in the world of hair loss disorders by doing research with you, actually, and that kind of introduced me to the disease CCCA, which we'll probably touch on shortly, and then also kind of piqued my interest in learning about other scarring hair loss disorders. And so now my practice is general dermatology and some cosmetic dermatology with a large focus in hair loss.
Wonderful. Well, I'm so excited that we're here together to talk because I always like to see my successful mentees, just give back, and you do such a great job of that. And one of the times that you did that was just recently at the Southeastern Consortium meeting of dermatology, where all the Southeastern programs gather with the residents and the faculty, and you gave that wonderful talk on hair loss, scarring hair loss, or hair loss, I think it was just in men of color. And I think that's a topic that we really don't spend a lot of time on. So maybe we'll take the first couple of minutes and talk a little bit about that, because that was wonderful information.
Absolutely. And so my decision to kind of talk on that topic was that I hadn't heard about it often. And so I've been to several different meetings and attended a lot of lectures where we've discussed scarring and non-scarring forms of hair loss. And what I found is that in majority of these talks, the specific focus on men was kind of lost. And I think one of the real reasons is because we kind of expect men to have hair loss. And when men experience hair loss, a lot of them likely don't seek dermatologic care just because it is something that they've seen, whether it's in other family members or other friends. And a lot of the treatment now even is navigated through these online platforms where they're able to order medications really without even seeing a dermatologist in person. So speaking on different hair loss disorders that can sometimes mimic androgenetic alopecia, which is the most common form of hair loss in men, I thought was really insightful for me to delve deeper into, and then also to introduce it as a topic for people to consider when they're making these diagnoses.
Yeah, absolutely. So, important diagnoses, what are they? What are the ones that you think we really need to spend our time thinking about, and how do we tell them apart from, male pattern hair loss, and can they occur with male pattern hair loss?
Yeah, so oftentimes when people have hair loss, they're experiencing more than one type. And so I think probably a large portion of men do have androgenetic alopecia or male pattern hair loss. But other sorts of scarring disorders, such as lichen planopilaris, central centrifugal cicatricial alopecia, these types of hair loss can oftentimes mimic androgenetic alopecia, but they require much more of a focused process for diagnoses, and then also treatment that involves anti-inflammatory treatments, which is not usually required for androgenetic alopecia. So these are ones to consider highly when you're looking at a patient who has new hair loss, especially if they're experiencing symptoms such as itch or tenderness, or if you're doing their exam and you notice erythema or redness, or even scaling around the hair follicles, you want to maybe consider doing a biopsy or looking deeper using dermoscopy on different areas of the scalp to make sure that your diagnosis is correct. And then other forms of scarring hair loss, such as folliculitis, decalvans, and dissecting cellulitis, these often present in a more severe stage, and there's a quite long delay in diagnoses for these patients. So knowing the early signs can really help to make the diagnosis early and result in a decrease in the loss of hair, which is really what we're trying to do.
Right. So you talked a little bit about the anti-inflammatory treatments for some of these inflammatory conditions that mimic or, kind of come along with male pattern hair loss. Are they similar for men to the ones that we use for women? Is there a difference? And can we also treat with things that we would normally treat with, male pattern hair loss too?
Yes. So, one of the mainstays of male pattern hair loss treatment is minoxidil, and another is finasteride. And I often use these even in patients who have inflammatory types of hair loss too. But we also want to do things such as topical steroids and intralesional steroids if patients have inflammatory types of hair loss. And these are common treatments that we're using in women as well. So there's really not a significant difference in what we're doing for men versus women. And then other options include like oral antibiotics that are often used. And one of the most common ones is doxycycline. So these treatments may not be initiated if someone initially looks like they only have male pattern hair loss. These are not medications that you would use for traditional male pattern hair loss. But when you see those signs of inflammation, these are things that should be started earlier than later to preserve the hair that the patient has and hopefully decrease the spread of alopecia, at least to a significant degree as what would happen if they weren't on those therapies.
Right. And it's so important, I think, to get this message out to men because I think men think also that they just have male pattern hair loss. And so, they don't necessarily realize that when we're giving them this topical medicine or oral medicine, that they really have to consistently take it. I think that's true for women,
Yes.
of course, too. But for men particularly, they just want the stuff that they can get online and they're fine with that, but they're really not fine. So I agree with you. I think it's so important to tell them, there's two things going on here. There's the white blood cells attacking your hair follicle, and then there's also this growth issue, and we can deal with the growth issue, but we got to get the white blood cells down or else you won't have any hairs to grow. Yeah,
Exactly.
yeah. So
I
how
feel
do
like
you go ahead?
I was going to say, I feel like that's a huge part of the visit too, is explaining what that means, because most of them are coming in expecting the first two medications that we talked about, minoxidil and finasteride. This is what they're coming in for often. So we really usually have to do a lot of teaching to tell them, why exactly they're on anti-inflammatory treatment and what the outcome would be if they don't follow through with it.
Absolutely. Now, how do you like to follow your patients to show improvements? Do you just do a description, or what do you do in your notes and your charts?
Yeah, so I love to take photos. Clinical photos are very helpful, and dermatoscopic photos are also helpful for monitoring disease. And then, of course, descriptions. So I like to be very detailed in my clinical descriptions and then in my dermoscopy descriptions as well, so that I know exactly what I'm looking for during the subsequent visits. And I know exactly where to direct the therapies and how to assess whether they're improving or not. And then I also am very big on documenting symptomatology, because I feel like this is a huge way that can help to determine whether our treatments are working. So if patients are experiencing pruritus or itch, and they continue to experience this, throughout the topical medications that we're working, usually this is telling me that we need to add something else.
Absolutely. And that sort of focus seems great for the mildly inflammatory things. But now, what about these other things like folliculitis, decalvans, and dissecting cellulitis? They often take a little bit more, to really get them under control. So how do you sort of have your therapeutic ladder set up for those two?
Yeah, so for patients with dissecting cellulitis and folliculitis decalvans, I'm always starting an oral medication for them at the first visit, essentially. For patients who have more mild disease, usually topical therapies and maybe some intralesional treatment can work. But for patients with the dissecting cellulitis and folliculitis decalvans who are often coming in with severe disease, we're usually doing all three: oral
Mhm.
medication, topical, and then also intralesional steroids. So I'm kind of informing them along the way that and there are other options that we may be adding, and we're doing labs up front to kind of prepare for whether we need to add additional medications. And I'm preparing for a more intense treatment regimen for them, usually at the first visit.
What do you like to use? What are your most commonly, sort of go-to medications?
So doxycycline is
Hmm.
absolutely one of my first options, and
Hmm.
dapsone is another one that I
Hmm.
commonly use for these patients too. So I would say those are probably the two that I kind of reach for the most in
Hmm.
terms of antibiotic and anti-inflammatory oral medications, and then intralesional steroids for most of these patients. And then I'm usually using one of the stronger topical steroid medications, whereas for some of the more mild disease, we can sometimes use fluocinolone or some of the weaker topical steroids. But for patients with more severe disease, I'm usually using something like fluocinolone and even
Hmm.
clobetasol.
Yeah, I think that's right. I think when you give them something that really is going to work, and we don't worry about atrophy in the scalp, because the scalp
Exactly.
is so thick, and so they're not going to get it from that. What about isotretinoin? Where do you think that fits in for those two entities? Are you commonly using that, or where do you fit it
Yeah, so I've used
in?
isotretinoin and I've had kind of mixed outcomes with it. I find it to be more helpful in patients who have like concomitant severe acne. And so
Hmm.
it's kind of easier to get it covered. And usually these patients do experience some improvement in their acne, at least, even if their improvement in their scalp disease is mild. So I do reach for it. I don't always tend to find it as helpful as I would
Hmm.
like it to be, but I do find that it's helpful when they have severe acne along with scalp disease.
Mhm. Yeah, I like it too. I do. I use it, sort of get me to a different level. It
Mhm.
doesn't cure anything, but maybe it takes me down a notch,
Exactly.
and I can start to manage them a little bit better. Do you ever talk to your friendly neighborhood surgeons about treatment, in these patients, maybe more so for the dissecting cellulitis people? And if you do, when do you, pull the trigger on getting surgeons involved?
Yes. And so I, recently haven't had as much experience getting surgeons involved with my dissecting cellulitis patients, but I have more so with patients with acne keloidalis
Hmm.
who
Hmm.
have larger lesions and they're stable. We've done injections for them, or they, kind of need that next level of treatment. And so surgeons can be absolutely helpful because the majority of these lesions are not ones that I would excise on my own.
Hmm.
And so I find that kind of reaching for surgical treatment when I've already done some anti-inflammatory intralesional treatment for acne keloidalis, and we are, left with a large nodular like keloid plaque that really the only treatment at that point is excision. I find it to be helpful to refer them to surgery, and usually they're very pleased with the outcome for the most part.
Yeah, I think that's a definitely not something we do every day, but when you need it, it's so nice for them. It's a little bit hard to heal, because you got to go all the way down, to basically right over the muscle. And if you don't, it doesn't work. And so then they
Exactly.
and then they got to heal by second intention, which is, hard on people. But once they get past that, they do really well.
They do. I found it helpful to do your method of the cryo surgery
Mm,
before injection as well. So that's also been really helpful at getting these lesions to be a lot smaller. The cryo seems to make a big difference when we do that before injecting
yeah.
lesional steroids.
And yeah, we just have to tell them, you're going to have some downtime healing because you're going to get, some blistering and that sort of thing. As long as they're sort of prepared, I really like that method too. It's a little painful, but
Yes.
but they usually buck up because they do better. All right. Well, we did do a good job talking about the men. Now, what about women? We can talk about CCCA forever, but what about some of the hair care practices that might say interfere with our treatments? I think our colleagues probably need to know about that. What do you think about those types of things?
Yes, I think one of the biggest is kind of higher tension hairstyling. We all know about braids. I think locks is one that probably really should be talked about because a lot of my patients, when they're experiencing hair loss, their go-to is to switch from braids to locks or to
Hmm.
stop getting relaxers and start getting locks. And while locks can absolutely be maintained beautifully, and we can certainly have patients who are not experiencing worsening of their hair disease with them, there are certain things to consider. Well, one is that you're already pulling your hair to get it into the lock. So then also pulling it into an additional hairstyle is just an added layer of tension. So I always explain this to my patients, like if you're going to have locks, I probably wouldn't pull them into tight hairstyles. And then another thing to consider is how often they're being retwisted or relocked, and then how tightly that's happening.
Absolutely. We look at, we've done this together in clinic. We look
Mm-hmm.
at the base of those locks.
Mm-hmm.
People say all the time, oh, they're not tight. They're not tight. They
Mm-hmm.
don't hurt. And then you look and they're inflammatory at each
Yes.
individual hair with a perfect flambeau sign. And, that's when you turn that camera around. You're like, hey, this is
Yes.
showing us you may not feel it, but your hair is feeling it. So
Mm-hmm.
I think you're right. You have to really be on people about that because they think that they're doing something healthy when maybe sometimes it isn't. And it's almost like they come in and they say, well, what hairstyle can I have?
Yeah.
That isn't really putting tension on the hair. And it's very difficult with natural hair, especially if your hair is thick or very curly, very coarse. And you don't want people to feel like they have to do chemical relaxers. So yeah, we have to really guide them into things that can be helpful. Sometimes I talk about twists, two-strand twists
Mm-hmm.
can be helpful for patients that want some more of a natural style, but then they can also get to their hair. They can wash their hair because I also feel like people don't wash their hair when they have braids and locks.
Yes,
They're told by
exactly.
the stylist, don't wash your hair. What do you do in that situation?
Yes, and that is a very common issue as well. And so I think a lot of education about the importance of washing the scalp and how anti-inflammatory just washing the hair alone can be, even if you're not using a prescription shampoo, just washing more frequently is very helpful, even for conditions like seborrheic dermatitis. And so informing them on their disease state helps somewhat, but then also trying to give them options for ways to style their hair that doesn't necessarily require it not
Mhm.
to get wet. So I know a lot of my patients, they like to straighten their hair, their natural hair, and
Mhm.
water will revert it. So discussing several natural hairstyles that they can maybe do in the off week before they go back to see their stylist can be really helpful. But it is a challenge. There's so much societal pressure to have your hair done all the time and laid all the time. And so I find it really difficult sometimes for certain patients, especially my younger African American women who kind of feel that pressure to wear their hair a certain way. It typically is very difficult for them to navigate how to wash their hair more frequently.
Absolutely. And also some of these young girls are coming in and they do a lot of gels and there's,
Mhm.
this approach that is where you have these hairs gelled out right at the frontal hairline,
Mhm.
and the parents want me to talk about it, and talk about how bad it is, but the girls are sitting there rolling their eyes.
Yes.
They don't want to listen. So I do try to tell them, have you ever seen somebody without their edges? Well, you don't want to be that person when you're 30,
Mhm.
or 25, and they're kind of like, okay, because they think, well, it looks good now. I feel good about it now. So I do try to go, a little bit more in depth with my teens when their parents acknowledge it. Every now and again, I'll get, sort of pushback. I say, you shouldn't use these gels. And they'll say, nobody in our family has bad edges.
Yeah.
And I back off.
Mhm.
But I do try to tell them no gels. And I call my patients, or how I do in clinic. I call them on. I'm like, now you got gel in today, and they're like,
Yeah, you
oh,
do.
I had the wedding, and we're like, okay, but last time you said it was this other thing. The more you
Mhm.
use that, the less my treatments are going to work. So
Exactly.
yeah, so we have to be cognizant of that. Now, when you do have people, when you do recommend washing hair more frequently, what is your time? Do you think what is 2 weeks, 3 weeks? What do you think is the better time to interval for washing?
I tell everyone my goal for you is weekly. I would love everyone to wash their hair weekly, but I also understand that not everyone will or can do that. So I
Mm-hmm.
tell them no longer than every 2 weeks.
Mm-hmm.
So my goal is weekly, but if you have to stretch it, every 2 weeks is the longest that I would go. And
Yeah.
I find over time, most of them are kind of able to do that. At least that's what they tell me. And so, and so I find that that is helpful, at least, making it every 2 weeks, because many of them are only washing their hair monthly, if that.
Mm-hmm.
And a lot of that is due to the styling methods that they're using. And then I also tell them that when you have braids, you can wash your hair with braids. And so I think that helps. And then it also helps, like we were talking about dermoscopy and taking photos,
Mm-hmm.
and showing patients what their scalp looks like and explaining how some of these things can be improved by simply washing your hair or using the treatments. And that really tends to have a significant impact.
Yeah, absolutely. Now, what about pomades and grease? We talked a little bit about gels. What are your thoughts about, all these products? There's so many thousands of products to sort of help the scalp. There's probably, I don't know, tens of thousands, maybe hundreds of oils out there, Bentana oil,
Mm-hmm.
Arugula oil. What do you tell patients about the oils? Where can they use it? Can they use it on the scalp? Can they use it on the hair? What do you say?
I say you can use it on your hair. Scalp oils really are not benefiting the scalp much, and many people will react to oils and products that are used on the scalp. And so that also takes a lot of teaching. I think culturally, we all have been used to using oils on the scalp and oils on the hair, and we think that the oils make the hair grow faster by placing them on the scalp, and really it doesn't, and sometimes can worsen conditions like seborrheic dermatitis, which is very common in our community. And so I always advise them, if you're going to use an oil, use the prescription oil,
Yeah.
not one of the oils that we're using for hair growth or other means. I would focus on using those products on your hair and not on your scalp.
Yeah, I think we really have a lot of teaching to do. And, I always fret about what the best way is to do that. I don't have time to go to literally to every stylist and teach them. I
Mm-hmm.
think, thank goodness, a lot of stylists do know these things, but not all. So, is there any way that, you think we can get the word out? I mean, this is a great way. Obviously, this podcast is wonderful, but what do you think we should do? What do you think is an answer? I'm sure there's no one answer, but what do you think about it?
Yeah, I think it's multifactorial. I think we try to do our job with patients at the individual level with teaching, but of course, appointment times are short and it can be difficult. So, building that long relationship with patients and then maybe mentioning new topics during each visit is helpful. And then at a community wide level, I mean, we've had experience, when I was in residency, we did kind of a community event where we were
Mhm.
teaching hairstylists and trichologists about things that we see in clinic and advice that we give our patients in clinic. And I think more of these types of events at a larger scale where we are able to directly interact with hairstylists is probably one of the best ways that we're going to be able to spread the information. And I know there are several other dermatologists doing that great work. And so I
Mhm.
think that just continuing to do that will make a huge impact, because it's really our stylists who are boots on the ground teaching patients about their hair. And so as long as we're teaching the stylists and kind of collaborating with them, I think it makes even more of a difference.
Absolutely. Wow, this has been so fun, and I could probably take up the rest of your day talking with you, but I think we have to close up our insightful conversation. It's been very engaging. So thank you so much, Dr. Taylor,
Of
for doing
course.
this with me. It's been
Thank you for
great.
having me.
Yes, yes. So that wraps up this episode of Skin of Color Savvy. Dr. Taylor, thank you again. Hopefully, we can do many more of these, educational events together, because I just love it. We hope that you found today's discussion informative and inspiring. If you're interested in learning more about Skin of Color Society and its impactful work, I encourage you to visit skinofcolorsociety.org, because that's where you can reach all of our programs and reach us. Please don't forget to subscribe to HCPLive, which is the newsletters, and follow us on social media. Stay up to date on all the things that are coming up in dermatology and more. And we'll be back soon with another episode. Not me personally, but others. So be sure to subscribe to Skin of Color Savvy, because that's the only way that you'll get these notifications. Until next time, take care, and thank you for listening.